Hey everybody, welcome to the CyberMD USMLE Step 1 lecture over cardiac output. The goal of the heart is to pump blood, and therefore oxygen and nutrients, to all of the tissues of the body. The measurement of this pumping is known as cardiac output. Today we will be discussing cardiac output, which is a measure of the amount of blood pumped by the heart per minute. The cardiac output is determined by the stroke volume, which is the amount of blood pumped per beat. It is also determined by the heart rate. In order to fully understand cardiac output, we must also consider the other factors that affect it: contractility, preload, afterload, and myocardial oxygen demand. Stroke volume is defined as the amount of blood that is pumped out of the heart with each contraction or beat. It is a crucial parameter in determining the cardiac output, which is the amount of blood the heart pumps per minute, as discussed earlier. The stroke volume is determined by the difference between the amount of blood that is in the ventricles at the end of diastole, known as the end diastolic volume, and the amount of blood that is expelled during systole, known as the end systolic volume. To calculate stroke volume, you simply subtract the end systolic volume from the end diastolic volume. There are several factors that can affect stroke volume, including myocardial contractility, ventricular wall compliance, and resistance to blood flow. The strength of the myocardial contraction can have a direct impact on the amount of blood expelled during systole. As the strength of the contraction or contractility increases, the stroke volume will also increase. The elasticity or compliance of the ventricular wall can also affect the stroke volume. A more compliant wall may allow for a larger stroke volume. The resistance to blood flow in the vascular system can also affect the stroke volume. High resistance in the vascular system will result in a lower stroke volume. Understanding stroke volume and the factors that affect it is essential in understanding cardiac physiology and pathophysiology. A decreased stroke volume can be indicative of cardiac dysfunction, such as heart failure, and may require interventions to increase the stroke volume. Contractility refers to the ability of the myocardium to generate force and pump blood. Factors that can affect contractility include the presence of hormones such as epinephrine and thyroid hormone, as well as changes in the levels of ions such as calcium and potassium in the myocardial cells. Certain medications such as digitalis can also increase contractility by affecting the levels of ions in the myocardial cells. The effect of hormones and medications on contractility can be explained by several mechanisms. Epinephrine and other catecholamines can increase contractility by stimulating the protein kinase A pathway, leading to an increased amount of intracellular calcium ions. Digitalis and other drugs can inhibit the sodium-potassium pump, leading to an increased amount of intracellular calcium ions. Calcium-induced calcium release is a mechanism that occurs when the influx of calcium ions into a myocardial cell during depolarization causes the release of stored calcium ions within the cell, leading to an increased contractility. As you can see, in all of these mechanisms, an increase of intracellular calcium leads to an increase in contractility. However, there are also several factors that can decrease contractility. Beta blockers can decrease contractility by reducing the amount of intracellular catecholamines. Heart failure, acidosis, and hypoxia can all lead to decreased contractility by reducing the availability of oxygen to the myocardium. Calcium channel blockers can also decrease contractility by reducing the amount of intracellular calcium ions. Preload refers to the amount of blood that is present in the ventricles of the heart at the end of diastole, which is the relaxation phase of the cardiac cycle. This amount of blood is an important determinant of cardiac output, as it affects the subsequent contraction or systole of the ventricles. The amount of blood that is returning to the heart from the systemic circulation is the primary factor that determines preload. The blood may enter the right ventricle via the vena cava or the left ventricle from the pulmonary circuit. There are several factors that can affect preload and influence the amount of blood that is returning to the heart. One important factor is the total volume of blood in the circulatory system, known as the blood volume. If the blood volume is increased, for example, fluid administration in a severely dehydrated patient, the preload will increase. Another factor that can affect preload is the venous tone and resistance. Venous tone refers to the degree of contraction of the smooth muscle in the walls of the veins, which helps to maintain blood flow back to the heart. If the venous tone is decreased, as in certain medical conditions, blood may pool in the veins and not return to the heart as effectively, leading to a decrease in preload. Additionally, compliance of the ventricular wall can also affect preload. Compliance is the ability of the ventricular wall to stretch and fill with blood. If the ventricular wall is stiff, the heart may not be able to fill as effectively, leading to a decrease in preload. Conversely, if the ventricular wall is compliant, the heart can fill more easily, resulting in an increase in preload. Afterload refers to the resistance that the ventricles of the heart must overcome in order to pump blood out of the heart. This resistance is an important determinant of cardiac output as it affects the ability of the ventricles to contract and eject blood. Several factors can affect afterload and influence the resistance to blood flow in the aorta and peripheral vasculature. One important factor is hypertension, or high blood pressure. Hypertension increases the resistance to blood flow in the peripheral vasculature, leading to an increase in afterload. Similarly, atherosclerosis, or the buildup of plaque in the arterial walls, can also increase the resistance to blood flow and lead to an increase in afterload. Another factor that can affect afterload is the compliance of the aorta. Compliance is the ability of the aorta to stretch and accommodate the blood flow. If the aorta is stiff, the heart may have to generate more pressure to pump blood through it, leading to an increase in afterload. On the other hand, if the aorta is compliant, the heart can pump blood through it more easily, resulting in a decrease in afterload. Increased afterload leads to increased wall tension in the ventricles, which can cause thickening and hypertrophy of the left ventricular wall. It's important to note that thickening or hypertrophy of the left ventricular wall can make it harder in the long run for the heart to pump blood. There are a few ways to decrease afterload in order to reduce the resistance to blood flow and improve cardiac output. Arterial vasodilators are medications that relax the smooth muscle in the walls of the aorta and peripheral vasculature, thereby decreasing resistance and reducing afterload. Additionally, ACE inhibitors and ARBs are medications that can decrease both preload and afterload secondary to their effects at the levels of the kidneys. Myocardial oxygen demand refers to the amount of oxygen that the heart muscle or myocardium requires to contract and pump blood. This demand is an important determinant of cardiac function, as an imbalance between myocardial oxygen demand and the supply can lead to ischemia, or a lack of oxygen to the heart muscle. Potentially, this may result in a myocardial infarction, more commonly referred to as a heart attack. There are several factors that can affect myocardial oxygen demand and influence the amount of oxygen that the heart muscle requires. One important factor is the heart rate, or the number of times that the heart beats per minute. A faster heart rate increases the demand for oxygen as the heart muscle contracts and pumps blood more frequently. Another factor that can affect myocardial oxygen demand is the contractility of the myocardium, which refers to the strength of the heart muscle's contraction. Increased contractility leads to stronger contraction and therefore greater demand for oxygen. Additionally, the amount of blood that is being pumped, known as the cardiac output, also affects myocardial oxygen demand, as pumping more blood requires more oxygen. Myocardial oxygen demand is also affected by the afterload, which is the resistance that the heart muscle must overcome to pump the blood out of the heart. Proportionally, increased arterial pressures will cause increased afterload, which can lead to an increase in myocardial oxygen demand as the heart muscle has to work harder to pump blood out. Remember, we just talked about all of this on the last slide. The diameter of the ventricle is also another factor that can affect myocardial oxygen demand. Increased wall tension leads to increased diameter of the ventricle, and this can lead to an increase in myocardial oxygen demand as the larger ventricle requires more oxygen to contract and pump blood. On this slide, you will find several equations for calculating some of the factors that may affect or be relative to the cardiac output. However, I will not be covering them in detail here. You should be familiar with them and their underlying principles as they relate to both pathologic states as well as normal physiology. In conclusion, cardiac output is a measure of the amount of blood pumped by the heart per minute. It is determined by the stroke volume, which is the amount of blood pumped per beat multiplied by the heart rate. The other factors that affect cardiac output include contractility, preload, afterload, and myocardial oxygen demand. Understanding how these factors interact is essential for understanding cardiac physiology and pathophysiology. Thank you for listening.